Thank you, ma'am. I would be speaking on anterior segment imaging, and this is pertaining to angle closure glaucoma. So if you look into imaging, we have gonioscopy, as been reiterated by all the stalwarts, that it remains the current reference standard. However, it is a subjective assessment, and all the diagnosis that we do is based on the gonioscopic findings. And it is a subjective, the disadvantage being that it is a subjective assessment. It has contact procedure. There may be inter-observer variability, and different lenses that we use can alter the angle appearance and the interpretation. Therefore, we needed an objective assessment to visualize the angle structures. So that is when the use of anterior segment OCT has come into vogue, and not only in visualizing the anterior segment, but also angle analysis, lens analysis, and bleb analysis. So in the quantitative assessment, if we look, the prerequisite for quantitative assessment is the identification of the scleral spur, which is seen as a bump in the inner wall of the sclera, and this is the thing that the observer or the person has to mark. Once this is marked, for all other angle assessments, the machine itself has inbuilt tools into it, which measures the angle opening distance, various other angle parameters like TISA, AOD 500, etc. And the newer thing that has come into vogue is the iridotrabecular contact index, that is known as the ITC index. It is a quantitative measure of the extent of angle closure across 360 degrees of the angles, and it is expressed in percentage. If you look into this, we can see that the angle is totally closed, and if you look at the graph, here we can see that 94% of the angle is closed, and 45 degrees of out of 360 degrees, 45 degrees was not visible because of the lids. So in the quantitative assessment, here we can see that before doing a cataract surgery and after doing a cataract surgery, how the amount of angle has opened up. And if you look at the ITC index, above it was nearly 100% closed, and here we can see that 74% has now it is 74% open. So if we can also do a qualitative assessment, if we look at various serial photographs closely, we can see at the top how the angles are closed. Here it is narrow, and the lowermost figure we can see the angles are totally open. We can also visualize plateau iris configuration. For these, we have to clearly look at the scans, and we can see that there is a steep rise of the iris against the scleral wall, and then there is a acute angle change in the iris pattern, and this is how we can also see the plateau iris configuration on the anterior segment OCT. And secondary angle closure glaucomas, especially when these young patients with acute rise in IOP, and you look at the anterior chamber, it is on the shallower side, you do a gonioscopy, it shows occludable angle, you are always suspecting something which is secondary. So when you do anterior segment OCT, we can also see that there is a fluid which is there, suggestive of ciliary body effusion. There's also a very high definition angle visualization, where we can see the structures of the trabecular meshwork, the Schwemm's canal. This is a very high definition view doing a laser peripheral iridotomy, and post we can clearly see how the angles have opened up after doing a peripheral iridotomy. Then we also have a 360-degree gonioscopic view. So in this is especially useful when you are doing some angle-based surgeries for the patient, where you exactly want to know which position is the peripheral anterior synechiae, and there you want to target that part particularly in the OT. Especially in this, we can see that in the supratemporal area, we want to do our goniosynechiasis in this patient. Then we come on to the lens analysis. So in the lens analysis, as the previous IC also reiterated the importance of the thickened and the anteriorly placed lens, which leads to the angle closure. And here we can see how the lens vault has increased and the lens thickness is totally overall increased. We can, in patients who are operated, it is very useful to look at the bleb wall, bleb thickness. In cases which patients who have very thin cystic avascular blebs, where we want to do some bleb remodeling procedures, we can do these scans. We can also see there is underlying scleral defect. You can see that there is no intensity here, and one can be well prepared for the OT and without any surprises. And we can look at the ostium, whether the ostium is blocked, how the bleb is functioning. Uh, uh, then next, one should also know about ultrasound biomicroscope, that is the UBM. So the clinical utility, again similar, it is similar to that of the AIOC. Again, qualitative and quantitative scans can be done, but one should remember that anterior segment OCT cannot visualize anything behind the pigment epithelium. So that is why we need the UBM for those cases, and especially in cases where we want to diagnose malignant glaucoma, which this is basically a very important and diagnosis which needs to be made early, because earlier the diagnosis, earlier the intervention, and the risk of irreversible vision loss is avoided. Then various lens-induced glaucomas, we need to know what is the cause. Like this, in this there's a subluxated lens, in this there was microspherophakia, then we have a very thickened phacomorphic type of a secondary glaucoma, and anything which is like iris cysts and ciliary body tumor, we need UBM to help aid in the diagnosis. So if you look at the advantages of the anterior segment OCT, it is non-contact, it is fast, and a 90-degree technician-patient interface. The only limitation being that anything behind the pigment epithelium cannot be visualized, and that is when we want to use UBM to aid in the diagnosis in such complex cases. So to summarize, imaging the anterior chamber angle is germane in understanding the angle anatomy and pathophysiology of angle closure glaucomas. Gonioscopy still remains the gold standard, and AIOC being a non-contact procedure enhances visualization of angle structures, provides a 360-degree evaluation of the angles, and 3D imaging of the anterior segment. And UBM being a contact procedure, it is useful in particular cases, and multimodal imaging is useful in decision making in various complex secondary or combined mechanism glaucomas. Thank you.
Thank you, Dr. Angmo. She's really covered all the important aspects of imaging. You may think that imaging is not really required, and good clinical evaluation gives you most of the input. But these imaging modalities have helped us understand the complex mechanism of angle closure glaucoma in research, and there are clinical applications which she has described well. So thank you. We also have a Gono pen which has been developed by Dr. Mani Bhaskaran when he was at the Singapore National Eye Center, and that becomes commercially available. I think it will be a really useful tool to use.